So we're just going to review some of the things that are highlighted in the guidelines related to asthma management. These are my disclosures. And learning objectives, we'll start with just some very brief fundamentals that are highlighted in the guidelines, and then we'll spend a little bit of time talking about some of the new and changing existing therapies that are available for asthma, and briefly at the end talk about some new things in severe asthma. So when we think about asthma, one of the common pitfalls is to make sure, is it asthma, right? If treatment is not working for a patient, then we have to take that step back. And this is highlighted very clearly in the guidelines, that we have to know the diagnosis and make sure that we take that step back and think about it. And there is literature that shows that many patients referred for asthma do not have it, and many times that is related to a lack of objective testing. So that's something that we really should think about. The other thing that comes up commonly is cough variant asthma. And it certainly is an entity, and we have to think about it. The actual literature that initially described this was a very small subset of patients that actually had methacholine challenge responsiveness that responded to therapy. But we also have to think about the upper airway and the connection between the two and make sure that we don't have something going on in addition to asthma. It doesn't have to be one or the other. Sometimes it's both, and we have to think about both in order to get a therapeutic response for our patients. The last thing just to highlight, and when we think about diagnosis, is the whole area of asthma, COPD, and asthma-COPD overlap. And this is important because the guidelines highlight clearly there is a different role for the inhaled corticosteroids when we're thinking about these different entities. Obviously, if we think it's asthma or asthma-COPD, inhaled steroids have a very essential part in the management of those patients. But LAMA and LABA without ICS is actually not recommended. However, if we have a patient with COPD, just the opposite really is true, and that we really want to focus on bronchodilators with LAMA and or LABAs or both. And ICS certainly can be used, but it's really in a subset of patients who are having recurrent exacerbations and or who have an eosinophilic phenotype. And so that's an important distinction to think about in our diagnosis and treatment of patients. So if we think it is asthma, then the next question is to kind of take a step back and think about what type of asthma is it? And as Dr. Althoff gave us a nice overview just recently, such as an obesity asthma, right? There's certain things to think about in that endotype that we have to think about. And we just think about phenotypes and endotypes. When we started thinking about this in trying to dissect types of asthma, we started thinking about clinical phenotypes, which are really a collection of patient characteristics that seem to identify subtypes. And ideally, these would be mutually exclusive, but unfortunately, in real life, they're not. So they aren't as useful in helping sometimes distinguish what type of therapy to use. However, endotypes really can be much more specific and more accurate in identifying subtypes of individuals and who may actually have a different targeted therapeutic response. And so that's something to think about as we subdivide our patients with asthma and categorize what type of treatment might be best. Certainly in the ambulatory setting, the guidelines do highlight the readily available of certain biomarkers that are available and easily obtainable in the ambulatory setting, including blood eosinophils, serum IgE, and FeNO. I will call out sputum eosinophils are certainly used in the research arena, but really not readily available in the clinical lab on a routine basis in the ambulatory practice. The other thing to highlight here is FeNO is certainly useful and is a very useful marker for indicating T2 high inflammation. But the guidelines clearly say it should not be used in isolation, but can be used as part of a management strategy for our patients. So when we think about asthma and we start therapy, most patients with mild to moderate asthma will actually respond nicely to standardized ICS-containing regimens. But if a patient is not responding nicely to that initial foray into a therapeutic change, before we jump to the idea that this is severe asthma, we need to take a step back. And the guidelines are very clear on the emphasis on this, that in thinking about a comprehensive management and care for our patients for asthma, we really need to think about this distinction between difficult to control asthma and severe asthma. Because difficult control asthma is an entity that has other comorbid things that are playing a role in our symptoms and our management of that patient, such as comorbidities, but also modifiable risk factors that if we really delve into the patient's history and what's going on, we can discern that there may be something else that's driving these symptoms. And also thinking about from the socioeconomic perspective and the strategies to think about patient adherence and inhaler technique. And I think the inhaler technique is something that I think we sometimes don't pay enough attention to, and especially on a regular basis, making sure that our patients haven't kind of fallen off the wagon in using those inhalers and using them correctly. So the last kind of fundamental I want to highlight that the guidelines really do put some strong emphasis on is the goals of therapy for our patients with asthma. And that is really the idea of asthma management is personalized, but it's a cyclic, iterative process. We assess, and they recommend actually with a standardized instrument, the validated instruments that are commonly available, such as the ACT, the ACQ, the Asthma APGAR. There's several out there, but we basically need to assess, adjust therapy based on that assessment, and it can be stepping up or stepping down. And I think that's an important point that we sometimes forget to do, and that is if a patient is doing really well, can we actually step down therapy? But so you assess, you adjust therapy by stepping up or stepping down, and then you review. But that, as highlighted nicely in the GINA guideline figure there, is really a cyclical process. Continually reassess, see if you have to make some changes, and move forward. And so that's another area that the guidelines really strongly emphasize, is a cyclic, personalized management of therapy for our patients with asthma. So now I'd like to switch gears a little bit and talk a little bit about one of the newer changes in the guidelines and the emphasis that they're putting forth in the most recent guidelines, and that is the new uses of existing therapy, and in particular ICS as part of rescue therapy. I'll highlight a couple of the kind of the background information that really kind of put this forth as something to be considered, and it's really kind of threefold. One, first, as I mentioned, inhaled steroids are the mainstay of treatment for asthma, but adherence to daily ICS use is poor. Some studies have documented that adherence to this regimen is as low as 25%. Also, there is an overemphasis on the use of short-acting rescue therapy by patients to control symptoms. And we also have very good data in the literature to show that this over-reliance on rescue therapy is actually associated with increased morbidity and mortality. And then the third point is that asthma exacerbations do occur, and occur even severe exacerbations in mild asthma. And so taking those three kind of ideas together, this concept of using inhaled corticosteroids as part of rescue therapy had really started many years ago. And I just put a quote in here from actually a manuscript that Paula Byrne wrote. This was, I think, back in 2005. But again, this idea that we should start thinking about ICS should be part of our rescue therapy. Just to highlight, there's very good scientific evidence that backs this idea, that the two are actually synergistic, working together. Corticosteroids actually increase the expression of the beta-2 receptor, and so that can help having more availability. But then actually beta-agonists actually help to potentiate the mechanism of action of corticosteroids. So there really is a play back and forth why the two together actually have a synergistic benefit. Just a little bit about terminology, just so we're all on the same page. And I highlight here particularly SMART and MART therapy. SMART was kind of the terminology that we've used for several years. It actually does not, even though the majority of the early studies in SMART therapy were with Symbicort. Symbicort actually does not mean the S in SMART. It's actually single maintenance and reliever therapy. But because of that confusion, a lot of people have moved away from using SMART, and now we're talking about MART, which is maintenance and reliever therapy, just getting rid of the S. The newer term that's out there is talking about AIR, which is really just the idea of having ICS and the formoterol or the albuterol using them together as an anti-inflammatory reliever therapy. And then the fourth term, which I will talk a little bit about in a minute, is called Pardix, which is patient-activated reliever triggered inhaled corticosteroids. And we'll cover that in a couple more minutes in more detail. And here are just a couple of the available options in the U.S. Basically budesonide, which is formoterol, and Symbicort is a brand name, but now it's available in a generic. Mometasone and formoterol are Dulera. I think it's important to note that both these medications are FDA approved for the use of asthma, but the indication of using them as needed is not FDA approved, and we'll talk about that in a minute and why it creates some issues and barriers to their use. I just put up here fluticasone formoterol because it is out there, but it's not FDA approved in the US, and so it's not something that we use. The newest kid on the block is actually the budesonide albuterol, which is Airsupra, and so that was just recently approved, and that does have an FDA indication for reliever use. And so this one is something we're just starting to incorporate and think about how that is going to play out with the use in our treatment of asthma. And then we'll talk about Pardix in a minute. But that is a methodology by which you can use any ICS preparation, but then instruct patients to use their ICS every time they use their reliever. So let's talk a little bit about how the guidelines are incorporating anti-inflammatory reliever therapy into the guidelines. And there is an important nuance between the GINA guidelines and the NAEPP guidelines, in that in step 1 and step 2, NAEPP does not formally recommend as their initial preferred recommendation air therapy. They actually still list rescue SABA as the treatment for step 1. In step 2, they do start to actually at least mention that it can be a possibility that intermittent as-needed SABA and ICS used together is a potential option for treatment in step 2. The GINA guidelines, however, have fully embraced the idea of anti-inflammatory reliever therapy, and their preferred step 1, track 1 recommendations are for using ICS formoterol as needed for step 1 therapy. And so that is a critical and important difference between the two guidelines. Obviously, they still have as track 2, you can use ICS with rescue albuterol use, and that is a potential option. I've included this slide, but I'm not going to go over it in detail, but this just is for your reference to allow you to see some of the references and the evidence by which the GINA guidelines felt that they could make this recommendation for track 1 being a preferred ICS formoterol. GINA and NAEP actually are aligned when we go to step 3 or 4, and they both recommend that basically MART or SMART is an appropriate therapy for step 3 or step 4, and with clear evidence that it reduces exacerbations. And for SMART and MART, it actually does have the convenience of it's a single inhaler for both controller and reliever, which has been promulgated to say it decreases confusion from patients knowing which inhaler is controller and which is reliever. I think the important caveat here is that if a patient is using a non-formoterol LABA as their combination inhaler, then you cannot then use MART or SMART therapy, and that's very important to do. And so we just have to make that distinction. MART and SMART are only recommended for formoterol, long-acting beta agonist containing combination therapy. Obviously, with ICS SABA now on the market, that is different. And that can actually be used as the reliever on top of a non-formoterol combination agent. And again, just for reference, so that you have it, this is a summary of some of the evidence that really supports the use of SMART and MART therapy in step 3 and step 4 for both, this is for the GINA guidelines, but this data is relevant for both NAEP or GINA. So I just wanted to take a second to take a step back and talk about Pardix. And Pardix is basically, again, it was a randomized but a pragmatic trial looking at the use of ICS, and it could be any ICS, but in this particular trial we did provide QVAR. And then they were educated on the idea of anti-inflammatory reliever such that every time they took their short-acting beta agonist, they had to also take their inhaled corticosteroid. And I think the reason I highlight this trial is that it shows that it's not just the single inhaler that can actually achieve these results. It's actually the concept of the anti-inflammatory reliever, because the results of the Pardix trial were actually equal to or even slightly better than the results that had been seen with SMART therapy using a single inhaler of Symbicort. So you can actually have patients educated to use the two together. And so we saw a decrease in exacerbations, but we also saw significant improvement in asthma control, improvement in quality of life, and days lost from work and school. So why have Pardix? There's really a couple reasons to think about having this additional option. First, it is recommended as an alternative in the guidelines, so it's certainly consistent with the guidelines. But then there are a couple of issues with ICS formoterol that we actually have to think about, and that's really related to the fact I talked about earlier that it's not indicated for as-needed use. Therefore, insurers don't always cover it. And it's a cost issue for many patients that they just cannot actually get that therapy. In addition, even if you can get the therapy, you can have trouble with having a patient refill the medication before 30 days is up because they've used more than their 2 puffs BID. So that there are still some real barriers to using ICS formoterol as a single inhaler because of cost and insurance issues. And so it's just something why this is an option. I think the other issue I just want to highlight is that SMART or MART therapy does not translate well for patients who use nebulizers. And we actually incorporated that into the Pardix trial, and patients actually had to use their inhaled steroids every time they used a nebulizer. And so again, we saw efficacy and effectiveness in those patients who use nebulizers. So it is an alternative for that patient population. Just briefly, non-eosinophilic asthma. Obviously, just to highlight that the guidelines do recommend potential add-on therapies of tiotropium or any long-acting muscarinic agent, and potentially azithromycin. There is data in both of those as add-on therapies for people who are not responding to conventional standard therapy. And then for severe asthma, we have a newer kid on the block over the last year or so. We have the biologics that have been available for several years, but starting last year, we have the availability of tezepelumab, which is indicated for both eosinophilic and non-eosinophilic asthma. And in 2018, the Institute for Clinical and Economic Review actually reviewed the data related to the 5 available biologics at that point in time and came out with the recommendation that there was not a clear superior biologic one over the other with regard to exacerbations rate, lung function, or quality of life. And then when tezepelumab came out, they actually added to that, again saying there was no clear evidence that one was superior to the other. So they don't have clear recommendations of one biologic over the other. And so really, when we think about picking a biologic, we really have to think about other factors that help us on a personalized way, and that goes back to what we talked about a few minutes ago. The guidelines talk about a personalized approach, looking at the patient and what really they need, and looking at things like, first of all, have they used a prior biologic? Do they have insurance issues that will guide you one way or the other? Is it T2 or non-T2 asthma? Because that will certainly drive. And remember also, are there comorbidities? Because some of the biologics have indications for other comorbid conditions, so it's important to think about that. And just the last point I want to make is that the guidelines also talk about, just as we talked about the goals of therapy and this iterative approach, there is the possibility that if you have a suboptimal response to one biologic, it's very reasonable to think about, is there a different biologic that will give you a better response? And this idea of taking a step back, looking closely at the patient, making sure we're not missing some other comorbid condition, anything else that's driving the symptoms, but then also switching to another biologic actually has a reasonable efficacy of getting improved symptoms if you do that. And I've included this table in the slide deck for you, but I'm not going to go through that. But this exactly goes through some of the administration, other indications, and the information that helps you think about what are the differences between the biologics as you think about your patient and which would be the optimal one to go with them. And so I thank you for your time and attention, and looking forward to any questions.